Welcome to Tiny Talks in Physiology. Today, let's discuss a case scenario which was asked in January 2024 Physiology Paper 1. A 55-year-old man who is a chronic smoker came with complaints of breathlessness, wheeze, cough with sputum for past 5 years. On examinations, there is cyanosis present, wheeze present, crepitations present, and he was having barrel-shaped chest. Investigations showed RBC count is increased, forced vital capacity is reduced, and forced expiratory volume in first second is reduced to 60%. Now the first question is, what is the diagnosis? So when there is a reduced forced vital capacity and also forced expiratory volume 1, we can understand that there is a moderate airflow obstruction. And we know that the symptoms are present for the past 5 years, that is breathlessness, wheeze and cough with sputum is present for past 5 years. So it is a chronic case. He is a chronic smoker, which is a predisposing factor, and we can see there is a barrel shaped chest. This is classically seen in chronic obstructive pulmonary disease. So the diagnosis of this case is chronic obstructive pulmonary disease or COPD, and the positive factors favoring the diagnosis is the age of the patient is 55 years, symptoms present for the past 5 years, smoking is present, cough with sputum is present, and the person is having a barrel-shaped chest, reduced FEC and FE1, and the presence of cyanosis. Now the second question is, draw a neat labeled diagram of a spirogram. So while drawing the diagram of a spirogram, make sure that you mark the x-axis and y-axis clearly. X-axis is time and y-axis is lung volumes. So you have to first mark all the volumes. So the first volume is tidal volume, which is the amount of air inspired or expired during normal quiet breathing. Now next is inspiratory reserve volume, that is the extra amount of air that is inspired after a tidal volume during a forced inspiration. Then similarly expiratory reserve volume is the extra amount of air expired after normal expiration during forceful expiration. Then you have to mark the residual volume. Residual volume is the amount of air present inside the lungs even after an forced expiration. And next, that completes the volumes. Then you have to mark the capacities, that is inspiratory capacity, that includes the inspiratory reserve volume and the tidal volume. Then next, the vital capacity includes the inspiratory reserve volume, tidal volume and expiratory reserve volume. Then next is the functional residual capacity, that is the amount of air that is present inside the lungs after a normal quiet expiration is called functional residual capacity. The total lung capacity includes all the values, that is the vital capacity plus the residual volume will be giving the total lung capacity. The next question is, describe the physiological basis for changes in RBC count and forced vital capacity. So RBC count is increased in this case. Let's see the reason for that. There is a moderate airflow obstruction because we saw that FEC and FE1 is reduced. So there is a moderate airflow obstruction. So there is a reduced oxygen that is reaching the lungs for the gaseous exchange. This is causing a chronic hypoxia. Hypoxia will be stimulating the production of erythropoietin, and erythropoietin will be producing more amount of RBCs, thus increasing the RBC count. Now coming to the next one, that is forced vital capacity, it is decreased in this case. So forced vital capacity is the amount of air expired forcefully after maximum inspiration. So when in this case there is a narrowing of the airway or there is an increase in resistance. So because of this there is an there is a obstruction that is created inside the lungs. So air is trapped inside the lungs. When air is trapped inside the lungs, the person cannot exhale fully. He cannot expire fully. So there is a decreased ability to exhale fully. So this is causing a decreased amount of forced vital capacity. Now the fourth question is describe the timed vital capacity and its clinical significance. So timed vital capacity means the volume of air that a person can forcefully expire in a specific period of time. So fraction, that means the fraction of vital capacity that is expired in the first second of forceful expiration is called FE1 or forced expiratory volume in first second. Similarly, the fraction of vital capacity expired in the second of the forceful expiration is called FEV2. Then similarly on the third second, and at the end of fourth second whole of the air will be expired out. So normally the FEV1 is 83%. That means 83% of the vital capacity is expired out in the first second. FEV2 is 93%. That means 93% of the air is expired out at the end of second, and FEV3 is normally 97%. That means almost all the air has been expired, only a few left, and at the end of fourth second it is over. Now the importance of timed vital capacity is it helps in diagnosis and prognosis of various diseases. Second is it helps to differentiate between obstructive and restrictive lung disease because FEV1 is reduced in case of obstructive lung disease and it is normal in restrictive lung diseases. So by this we can differentiate between restrictive and obstructive lung diseases. The third one is we can understand the effectiveness of the treatment. That is, if it is improving, if FEV1 is improving, we can understand the effectiveness of the treatment. So these are the three importance of timed vital capacity. Like and subscribe my channel if you like my videos. Thank you.